Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to this evening's Lung Cancer Living Room, where we'll be celebrating not only Lung Cancer Awareness Month, but our military men and women. To those of you who are able to join us today during this meeting, and happy Lung Cancer Awareness Month again, I'm Danielle Hicks, Chief Patient Officer here at GoTo Foundation for Lung Cancer. And for those of you who might be first-timers and aren't familiar with our Living Room program, it's a support and education series created specifically with patients and caregivers in mind, with the ultimate goal of really bringing to you live, in real time, educational talks from key opinion leaders in the lung cancer community. We, of course, cover varying topics across the care continuum. This program, as I said, is for all of you watching. I want to make sure to give you all a shout out and encourage you to ask questions of our expert speaker throughout the program. Please engage with the conversation by posting questions online, whether you're watching through Facebook or YouTube Live. Our go-to staff are online moderating, and we'll be certain to get those questions to us. Bonnie is not joining us yet again. And I know a lot of folks out there keep asking why she's not here. And she and I had this conversation where she said it's just this online version is just sort of hard for her. She feels like half the time she's just sitting there, which sort of in code between us means maybe I talk too much. But she can't wait to be back and join us live in the living room here, hopefully in fairly short order. We're working on some plans and noodling some ideas to get everybody back in person in 2022. Another thing I'm going to remind you later in the program, if you find this living room meeting helpful to you and you'd like reminders about this program prior to our next meeting and would also maybe like information about other support services GoTo has to offer, please consider joining our patient and caregiver community at gotofoundation.org/living room. Thanks again for joining us. We're going to spend some time tonight focusing on the care our veterans can expect at the VAMC. There's historically, as most of you know, been a stereotype that veterans will maybe receive substandard care at the VA, that maybe they won't get in a timely manner, that maybe they'll receive worse care than at another hospital. And I'm here to tell you, I am thrilled to have Dr. Millie Das here tonight to talk openly about the care that veterans at risk and those diagnosed can expect to receive at the VA. I also want to say that the GoTo Foundation is proud to be partnering with the VA in multiple ways. We currently have a VA-specific lung cancer screening centers of excellence program in Virginia, Kansas, Alabama, Missouri, and California, with a path forward to include many, many more. We're also working on a new veteran-focused radio campaign that has been added to the Screen Your Lungs media campaign that launched this past summer. As well, we hosted a special VA track at our recent 3-day Centers of Excellence Summit for healthcare providers, focusing on lung cancer screening, diagnosis, and treatment with the VAMCs nationally. So with that, big mouthful of words, no wonder Bonnie thinks I talk too much, I want to get started. So tonight, our expert speakers are, as I just mentioned, Dr. Millie Das, who is Chief of Oncology at the Palo Alto, California VAMC, and also gives her time in clinic 1 day a week at Stanford Hospital. We believe, and I'm pretty sure her patients believe, that this unique experience has really created an opportunity for her to share what is working in the VA at the Palo Alto Center to other VA centers around the country, where she speaks in multiple engagements at VA centers nationally. We also have with us no one new to the living room, Larry Gershon, who is a veteran, survivor, and advocate. And he's going to share with us his unique experience since his diagnosis with lung cancer in January of 2013. So welcome to both of you. Dr. Das, before we get started with our main program, can you tell us a little bit about yourself, why lung cancer is an area of focus for you, and how you came to bring your talents to both the VA and academia?
Yeah, thank you, Danielle. And thank you so much for this invitation. I'm really thrilled to be here and to talk about the VA, which is so near and dear to my heart. I actually am from the East Coast. I grew up outside the Boston area. I did my college and medical school over in Massachusetts, and then chose to come out to Stanford for residency. And I also stayed on for my fellowship, which I finished about 10 years ago now. And straight out of fellowship, I joined at the Palo Alto VA as a faculty member, and I essentially maintained a joint appointment with Stanford University. For me, I really fell in love with lung cancer during my residency. So I had decided on oncology during medical school and my early residency years. And then I had connected with Heather Wakely, who many of you already probably know. So she was a junior faculty member at Stanford, doing, of course, really interesting lung cancer research and obviously providing excellent care to lung cancer patients. And so I decided to start working with her, and I got more and more interested in pursuing a path in lung cancer. When I finished fellowship, I knew I wanted to continue in academia, but I kept going back to my experiences at the VA both as a resident and a fellow. And I love the time that I spent there. I saw a lot of cancer patients at the VA, and particularly lung cancer. There's a lot of lung cancer at the VA. And so when I decided to take a faculty position at the VA, I had spoken to Heather, and I sort of decided that I also wanted to maintain my clinical practice at Stanford. And so I was sort of doing both really from the get-go. And I've been doing that now for 10 years. And it's been really wonderful. I really had wanted to develop expertise in lung cancer, and knew that I would really get the breadth of exposure, clinical exposure, with practices at both places. As you can imagine, at the VA, most of my patients are male. Most of them are older. Most of them are current or former smokers. Stanford is a very different patient population. We're in the Bay Area. We see a lot of never smokers. I get to see women at Stanford. I don't have very many female patients at the VA. So I've really been able to have this very broad clinical exposure through having both those clinics. So that's been really important to me, and it's been something I've really enjoyed and continue to enjoy. And so that's kind of how I got to where I am right now. And I started chief of oncology at the VA about 5-6 years ago, and that's been also really exciting. And I've been able to really focus on thoracic oncology, both at Stanford and at the VA. Again, at the VA, because there's so much lung cancer, I've really been able to be kind of the main person, along with one of my colleagues, Manali Patel, who also has a half-day clinic seeing lung cancer patients at the VA.
That's great. I love that. It's obvious just while you're telling your story how passionate you are about this by the smile on your face. So thank you so much for sharing. We're going to talk through the care continuum, beginning with those at risk and prevention and screening, and then running through those who are ultimately diagnosed and what they can expect there. So let's start a little bit about prevention. What type of preventative services does the VA offer to their patients?
So, as many of you probably are familiar with, the VA is the largest integrated healthcare system in the US. And so, what's great about that is that there are clinical reminders that come up in the VA medical chart for any given patient. I think being able to talk to patients, primary care providers, and pulmonologists and interventional radiologists through the chart is really one of the great luxuries we have at the VA. It's not as seamless and easy in Epic when I'm at Stanford, because of a lot of our patients are not getting their care necessarily at Stanford or their primary care, for example. So that's one of the great things that we do have, is this integrated healthcare system that we oftentimes will see what the clinical clinical reminders are, as far as, for current smokers, there's tobacco cessation that's listed as a clinical reminder. There's low-dose CT screening that's a recommendation for at-risk individuals. And so these are reminders that I think are very useful to primary care physicians when they're seeing patients in their clinic, so that they know to refer patients. So from the standpoint of a smoker, we have a Telequip program, which is great. So this is something we talk to our patients about. For patients who are interested, we put in the referral, and then they get contacted right away. And really, it's a pretty integrated group of, there's social workers, there's behavioral medicine or psychologists, specialists. There are people who are really kind of experts at some of the pharmacologic treatments for smoking cessation, and so they really go through that process with veterans. And then and I've been able to see this up close when I refer patients. They tell me, wow, I never thought I could do this. And they've been referred to Telequip, and they're started on a drug like Chantix, and they're able to stop smoking, which we know will improve their treatment outcomes and reduce toxicity from their therapies. And so that's been really tremendous. And to be able to have primary care physicians do that even before these patients come to see me as an oncologist, I think is great. But sometimes patients just aren't ready. And by the time they come to see me, maybe, hearing it from multiple people, they're then ready. So we do have the Telequip program, which is terrific as a preventative. And so, yeah, I'm talking more from the oncology perspective. These are patients who are already diagnosed with cancer, but of course the goal is to be able to identify at-risk smokers before they develop cancer and intervening with Telequip. And then just kind of to go ahead, Danielle, with this. I was just going to jump into screening after that, but.
I just want to ask one quick question about this Telequip program before we run into the screening conversation. By nature of the title of the program, Telequip, is it a virtual program? Do patients have to come? Virtual. It's all virtual. Okay, correct. I just wanted to kind of highlight that. Okay, now we can jump into screening. Let's talk a little bit about screening and what's going on over at the VA.
Yeah, screening is really one of those clinical reminders, just like getting a colonoscopy or whatever, kind of the recommended flu vaccine for the year. So screening is reminders that pops up. And I have just in my 10 years at the VA, with more wide adoption of the low-dose CT screening for high-risk individuals, I've been really able to see patients getting diagnosed at an earlier stage. Oftentimes, we are finding these tumors on these low-dose CT screens, and then either pulmonary or interventional will bring these cases to our tumor board. And so this is before people will present with symptoms. And so that's been really exciting. And so we find these tumors at an early stage. We're able to intervene, refer these patients for resection, send the patient to see a thoracic surgeon to be evaluated for that. Otherwise, if they're felt to be high risk, they're referred to me, and I refer these patients for radiation. And since we don't have radiation at our VA facility, we refer our patients to Stanford for their radiation treatment. So that's been really exciting to see. I think kind of as a nation, we're not doing a very good job with screening. And so I think this is something that is really important. And it's great to see that the VA is, really taking it seriously, and they are really wanting to screen our patients. We knew that during COVID that some of the screening reminders would not so much go ignored, but, even when we wanted to try to get patients to come in, they were reluctant because of, all, the risks COVID. I do think, and that was not just seen at the VA, but I think we saw that everywhere, unfortunately. So I'm hoping, we're gonna get people back for their low dose CT screens.
Yeah, you are really speaking our language here when it comes to screening and early detection. We sort of view it as this low hanging fruit, right? And based on the new Uspstf guidelines, just in this country alone, and this includes everyone, not just veterans, there's like 16 million people who currently are walking around that qualify for screening, and only roughly 4% of which are actually getting screened. So I love the fact that the VA, through their electronic patient records, has these clinical reminders that can then, go in, identify those who might qualify and have the conversation about it, right? Because I think that's where the big gap lies. People don't know what they don't know. And I think the general population doesn't know that lung cancer screening might be an option for them. So I think it's fantastic, the work that you're doing there. So I mentioned the USPSTF guidelines, and we talk about them a lot here at the living room and in other places. The current screening guidelines are currently tied to smoking, right? But we know that, in particular, our military men and women have exposures, right, to chemicals in burn pits and other things that might factor into not just, potentially lung cancer, but other lung diseases. Does the VA take into account, well, what does the VA do with those exposure patients, if anything, or what's the ultimate goal in that space?
Absolutely. So every veteran will meet with the benefits counselor to detail sort of their dates of service, what exposures they may have had. For Agent Orange exposed veterans, lung cancer is considered to be an Agent Orange related malignancy. And so this is something that we as physicians don't really spend a lot of time on, because the VA has already spent many hours thinking about this and how to approach this, and so we refer our patients to our social worker, who then also makes the referral to a benefits counselor, who really gets all the details, the nitty-gritty details about their service, about an individual service, and then talks to them about their lung cancer or whatever. It could be any type of cancer. It's not just lung cancer. There are a number of different Agent Orange related malignancies, and then that really helps them to come up with a service connection, and really allows them to tell an individual veteran what benefits that they're eligible for, they and their loved ones would be eligible for.
I think it's great. It's really taking that next step and going above and beyond in this space. And I'm thrilled to hear that this is happening at the VA in Palo Alto. You talked a little bit about stage shift and just being mindful of our patient population. Can you talk a little bit about what that actually means about these early detections and this stage shift that you see happening?
Yeah, I think the key with any screening is to really be able to screen at this critical point. So this forms where you're detecting the cancer at an early stage, and you're able to intervene to alter sort of the outcome for the individual. So I think that that's really a key thing, and so it was exciting that the NLST trial did show a benefit with low-dose CT screening for at-risk individuals, and it's nice to know that there's been a recent sort of inclusion, lowering of the age and the PAC years of smoking. Really, one of the major intents of that was to allow for more women to get screened, to allow for more patients of ethnic minorities to get screened. And so I think it's great. And if we can actually screen individuals before they have symptoms, and we can cut the tumor out with surgery, then we know that people are going to do better. So we know that survival outcomes are dependent upon stage, and so if we can intervene at an early stage, we know that people are going to do better. And I've been able to see that in practice, and it's been really great. And either patients are getting screened before the onset of symptoms, or sometimes patients are getting scanned for some other reason. Most often at the VA, they're undergoing a cardiac workup, and they get a CT scan, and they have an incidental nodule. And then that prompts further workup and biopsy. So I think it is really, really important to screen individuals. I think you bring up, maybe people who don't meet the criteria for screening, and what do you do with those individuals? I think that's one of the trickiest areas, right? And we know there are a lot of never smokers who end up developing lung cancer, and there's been a lot of data showing, other potential risk factors such as air pollution, and how do you quantify that, and how do you include these individuals in our screening programs? I think there's a lot of work now trying to expand the screening criteria so that we do pick up more patients.
Yeah, I couldn't agree more. And one of go-to's, main goals that kind of rolls up into our overall vision of doubling the survival rate is increasing, the rates of patients diagnosed early. And it's right now we're looking at it as sort of a three-pronged approach, and you touched on all three, which would be screening as being one, quality follow-up of those incidental nodules that are found because the patient's in there for something else, and then all the research that's being done to hopefully be able to bring to the table some more novel ways of identifying not just lung cancer, but cancers early. potentially in the blood. So thank you for that. I want to switch from this early detection space because I'm trying to be mindful of time, and I know we have a ton to cover. And I want to jump into that post-diagnosis care and the services that the VA offers its lung cancer patients. One of the things on our list to kind of talk about is disease specialists. Can you tell me a little bit about what that means?
Yeah, I think in oncology, I think we're veering more and more towards having disease specialists providing oncology care. As you all know, there's new FDA approvals coming out every week for oncology drugs, and so it's becoming harder and harder to be a general oncologist. And I think one of the goals is really to have oncologists who have special disease expertise providing care and really the latest treatments, the latest FDA approvals. And I think in my view, you really need that disease expertise in order to do clinical research and think about clinical trials and putting patients onto clinical trials at your site. And so that's been one of my goals as chief, has been to really bring in a group who have areas of expertise. So for me in lung cancer, there's so much lung cancer within the VA that I'm able to really focus on lung cancer. But I have colleagues who are lymphoma specialists. Of course, lymphoma is not as common a diagnosis. So this oncologist is a lymphoma specialist in addition to being a women's health, like a breast and ovarian specialist. So she has a few areas of disease expertise. There's a lot of GI cancer out there. So we have an oncologist who's specifically devoted to GI oncology patients. There's a head and neck oncology specialist at our VA. And again, we really take advantage of the fact that we have a lot of these veterans who have these very common types of cancer, and we'll have them preferentially see one of our disease specialists. There are certain tumor types that are very rare and that you're not going to necessarily be able to have these expert. Sometimes in those cases, we will refer these patients out. So of course, to academic centers like Stanford. There was a veteran, a very young veteran who was referred to us in recent months who had a very rare type of brain tumor that's seen more often in the pediatric population. Of course, none of us are experts in this, and so we were able to refer that patient to be seen by the pediatric neuro-oncology group at Stanford, who provided recommendations and actually provided the treatment for that patient. So that's one of the great things at the VA is if there is a disease that's being seen, and this is even outside of oncology, but if they cannot be served by the providers that are at the VA will allow for that veteran to be seen at a specialty care center where they can get that specialized care.
Yeah, I couldn't agree with you more. In this day and age, as you pointed out earlier, of precision medicine and so many different approvals and therapies happening. And lung cancer is not just one disease, right? It's multiple diseases and subtypes. And I've been saying for a long time that I think the expectation for a general oncologist to know everything there is to know about every cancer, whether it be solid tumor or blood cancer, is not only unrealistic, but I think it's almost unfair, right? And I know that this is a challenge. It's particularly difficult in some of the more rural. Sorry, I don't know why I always have trouble with that word. Rural areas where all there is a general oncologist. So it's heartwarming to know that the VA, in particular the VA in Palo Alto, is taking action in recognizing that and working towards those sort of subspecialties. We did get a question from online that I want to make sure to acknowledge, and maybe we have an answer, maybe we don't. Maybe we have a place that we can point him. He's in Winston-Salem, North Carolina, and he says he's a Navy veteran. He was diagnosed with non-small cell lung cancer, stage 4, in December of 2017. He's a never smoker. He lives 6 miles from a VA hospital, but can't get the health care there because he was told he didn't qualify due to financial income greater than $40K. He's in the system. He receives emails about lung cancer care, studies, groups, etc., but can't participate, and is wondering if you can maybe elaborate on qualifications to VA access.
That's a great question. I I do not. There are no income requirements as far as I am aware. So, Larry, I don't know if you have any other information on this, but my understanding is if you are a veteran, you are entitled to receive your care at a VA facility. And so I would always, it's funny in my kind of dual roles, I see some veterans in my Stanford practice, and then they find out that I'm a VA doctor, and I've been able to very successfully transfer their care over to the VA. And so it usually just takes, again, sort of connecting with one of our social workers or with one of the primary care physicians just to get this veteran into the system. And then they're able to get referred to see any subspecialty, including oncology. So my understanding is that you would qualify for care within the VA. And there is a VA hotline and a VA, I think just going on the VA website to find out maybe who to contact to get into the VA system, I think that would be kind of a first step.
Yeah, that's great. And I think one of the things I just want to throw out there too is through our helpline, we may be able to help you navigate that system and at least point you in the right direction to the right person to talk to where you are. So I don't know if Rocky can toss up, there it is. Please feel free to reach out to us, and we'll see if we can't help get you to the right spot for that. Okay. We already discussed a little bit about integrated healthcare systems and resources. We talked about it sort of up here, but for those who may not know what that means, can you just briefly define what an integrated healthcare system looks like?
Yeah, I think the main point of an integrated healthcare system is just where it's kind of a one-stop shop where you can get all your medical care sort of within a single building or facility. And so most of our patients are getting their primary care and then at the Palo Alto VA or at one of the satellite sites. And then they're referred to oncology. So we have a pretty large catchment area at the Palo Alto VA. So many of my patients do not really around here in Palo Alto, but many of them are coming from Stockton, Modesto, Sonora. So there are what we call CBOCs or community-based centers over there where patients do have access to primary care, for example. But then when it comes to subspecialty care, they're referred to a place like Palo Alto, which is just a larger facility, which really provides more access to more, additional types of care. So when patients are referred for biopsies, they're performed at Palo Alto. What's nice is that we're a small group. And so when a patient has a new diagnosis of lung cancer, so the primary care or the pulmonologist who performed the biopsy or the interventional radiologist who performed the biopsy will quickly send me a message. So we're all on this Microsoft Teams when we're logged in at work. We message each other. So I'm messaging people out on the East Coast at other VAs. They're online. They can see that I'm online and they send me messages. And so it works within interfacility and intra-facility. I mean, it's really terrific to have that kind of easy way of communicating just within care teams, even outside of our own VA facility. And so I think that's a really unique aspect of the VA. The other thing is we're our own insurance company. So, I can't tell you how frustrated I get when I'm working at Stanford and I remember that I have to deal with insurance companies, which you're all familiar with. So when I want to give a drug, I have to go through the, kind of approval process. That doesn't really exist at the VA. So if a drug is FDA approved, we can go ahead and give that drug that day. So there's none of this sort of waiting or, getting approval. It's really just a matter of, if it's a drug that's approved, I speak to the oncology pharmacist. I may have to quickly fill out what we call a non. The oncology pharmacist will approve it on the spot, and the patient can go to the pharmacy or to the infusion center to get their treatment. So that's one of the great things at the VA is just that it really is seamless. And then one of the other great luxuries I have is, if I feel that a patient needs a PET scan or a brain MRI or whatever imaging study, I'm able to do that again without insurance authorization. Because again, I think the VA really feels that veterans should get access to whatever care they really need, and they give all of the providers within the VA, including nurse practitioners, physician assistants, MD physicians, really that open access to ordering scans, whatever scan that they feel is warranted. And so there's none of this sort of, I didn't realize how much a PET scan cost until I, really started ordering them at Stanford, and they were getting denied. So that's the VA. I'm just ordering them all the time. So I think those are really some of the just few short sort of examples of some of the advantages of being part of this integrated healthcare system.
That's great. I'm getting a couple of comments online, and they're all relatively the same. So I'm wondering if now might not be a good time to kind of talk about no two VAs necessarily being alike, right? I just want to make sure that folks watching, understand that we're talking about Dr. Dass's experience specific to the VA, where she's the chief in Palo Alto, California. Some of the questions that are coming in are around some of the earlier things we were talking about as it pertained to exposure, screening, and sort of this integrated sort of EMR where we can go out and identify people who might qualify, saying that that's not necessarily happened in the past. I think other than to say screening hasn't really been around for all that long, I'm not really sure how we might want to answer that.
So, sorry. So just, I guess the question is,
so what they're saying is I hear people saying they hear what you're saying so far that is being offered at the VA here in Palo Alto, and they aren't necessarily seeing the same thing at the VA where they are.
They should have benefits counselors at every VA. And, they do, they have kind of a formulaic approach to this where they will go through. And again, I've actually not really been a part of this. I've been asked to write sort of letters of support in the past for specific patients. But my understanding is that they do really consider service and Agent Orange and other potential like burn pit exposure and things like that. And then they come up with sort of, whether they think that could be related to the cancer. As I mentioned, there's specific Agent Orange related malignancies. So these are things that really are outside of any of us, like treating physicians. What we can we can certainly advocate for our patients. As you can imagine, it's, there's research out there, but it's difficult to link some of these exposures to cancer. So, the VA does have a way of handling this, and in each individual person's circumstances is so unique and different, and I think it needs to get considered. There's appeals. So I've also seen veterans who go through the process, don't get the benefits that they feel they deserve, and then they appeal it. There's always a patient advocate office at every VA facility. So if you feel like you're not getting the answers, you should feel free to reach out to the patient advocate. And so there's multiple venues that people can go in, to really make sure that they're getting sort of the answers that they hope to receive.
Yeah, that's helpful. And I just wanted to recap on this and the question that came up earlier about VA centers having benefits specialists, I think you called them, and patient advocate offices. So I think those are two important things to know. So if a patient wants to get screened at a VA, this is another question, do all VAs have screening programs? And if not, how would a veteran go about getting access to screening through the VA?
Yeah, great question. So, of course, if they're in the risk category, which would with the recommendation for screening. So, obviously, not every single VA is going to have radiology services. So, what happens usually is that the patient to a VA medical center that is closest to them to get that screening study done. That's how it usually works. And it usually starts with primary care. So the goal is to get a veteran connected with a primary care physician who makes sure that not just screening for lung cancer, but does the usual cholesterol, diabetes, other screening. And so this is just a part of that. And if that VA facility has labs, if it has diagnostic radiology, they'll go ahead and get it at that facility. If not, they are referred to the closest VA. If there is no VA that's within an hour's drive, then the patient is referred out into the community to receive care outside of the as part of the Mission Act. And so that's really kind of patients who can't get the necessary care within an hour's drive at a VA facility.
That's super helpful. So it sounds like you're saying the starting point is with a primary care provider or your general practitioner to start having the conversations
Exactly.
there.
Yep, exactly.
Okay. It looks like that's all the questions we have there for now. So let's move on. I want to talk a little bit about the, post-diagnosis, what that process looks like. And again, I'm being mindful of time. So if we could sort of bucket the biomarker testing for the appropriate patients, along with what's at the high level, what sort of expectations or potential therapies might be involved should someone test positive for a biomarker.
Yeah, I mean, I think, again, this is not just VA specific. One of the major goals for all medical practices is to perform next generation sequencing for our patients with lung cancer. And we would argue to be doing this even for patients with early stage disease. And I think that's really one of the goals, is to have that information up front to help inform treatment decisions. There are certain drugs such as osimertinib or Tagrisso that have now been approved in the early stage setting. And so this is why it's important. You need to know whether a patient has an EGFR mutation, even if they're diagnosed with an early stage lung cancer. So that is something that is being done, that should be done for every patient. How it's actually getting done is really dependent on a facility level. So, I run our thoracic tumor board at the Palo Alto VA, and that is kind of the forum where I discuss the process by which we need to do this, because I have sort of the attention of our pathologists and our surgeons and our interventional radiologists and our pulmonologists, and really talking about, okay, once you get so one of the goals, of course, it really starts at the time of biopsy. Make sure you're getting enough tissue to send for molecular. So that was one of the kind of major things that used to really annoy us as oncologists, is when we got enough tissue for a diagnosis, but then there was not enough for molecular testing, and you have to put the patient through a repeat biopsy. So our interventional radiologists and our pulmonologists know they need to do as many passes as they need to make sure that they have enough tissue. Many times, again, it depends on the facility. This is VA, and even outside the VA, we try to have pathologists there at the biopsy to confirm that they're seeing cancer, to confirm that they have enough tissue to send. And so that's, it's not always feasible in every case, but we really try to do that. So because we want to be mindful of the fact that we don't want to have to put patients through multiple procedures. And then that tissue is, at our facility, it's reflexively sent by our pathologists to Foundation Medicine. So the VA has national contracts with NGS companies, next generation sequencing companies. And so for us on the West Coast, it's Foundation. And so our pathologists are sending a lung cancer diagnosis for Foundation Medicine testing. And so that they're getting the results back, and then they're putting it into CPRS, which is the electronic medical system for the VA. And so in an ideal situation, when the patient's referred to me, I go into pathology and I can see that that's been performed, and I can see what the results are. Sometimes there's a lag between the results coming back and the pathologist putting it into the system, and then I just pick up the phone and speak to the pathologist, or I log into the Foundation portal myself. There's multiple ways of doing it, but this has now really become standard. required, and we're doing this. I really believe that this should be reflexive testing done through the pathology department. Many facilities are still having the oncologists reach out to pathology. That's another way to do it. I think it's just, unfortunately, it can lead to some delays. But I think it just, again, it takes the providers at an individual institution. And again, I'm not just talking about VAs. I would imagine this as communities as well, really just making sure that they have a streamlined process. So that we are doing that directly through our pathology department. They understand the importance. Once you identify a targetable mutation, then yes, then that's when it comes to the medical oncologist's attention to really prescribe the appropriate therapy. And as I mentioned before, we have a number of different FDA-approved targeted therapies that we are able to provide. Again, one of the great advantages of the VA is being able to provide that without sort of this insurance authorization approval process. We're able to do that pretty seamlessly.
I love it. Like I said, I think I said it earlier in the program, and you're really speaking our language, and the work that you're doing up there at the VA in Palo Alto is incredible. I just want to stop for just 1 second and kind of again reiterate what Dr. Das was just saying and talking about, once you get your biopsy. She used an acronym NGS, or next generation sequencing. And you might have heard either me or some of my colleagues or other folks out there also call it comprehensive biomarker testing. And it's really the same thing. And it's really taking a piece of the tissue sample from your tumor, running it through this process to see if you have any of these mutations, so we can identify what might be driving your cancer. And this is where the personalized medicine piece comes in, and where, to Dr. Das's point, a lot of targeted therapies have been approved specific to some of these submutations of your lung cancer. Dr. Das, can we talk a little? Go ahead.
In the VA, there's actually this thing called the LPOP program, which is the Lung Cancer Precision Oncology Program, which is really focused on this exact thing that you mentioned, Danielle, about not just doing the testing, but identifying the patients who do have targetable mutations. I'll tell you, when the FDA approved sotorasib for KRAS G12C mutated patients, that was really exciting that we finally got a drug that specifically targets that mutation. And the next day, I got an email with a list of my patients within the VA who have that specific mutation. And so the VA has this great way of being able to, they have this data because, we are sending to Foundation. So they just queried the Foundation database for veteran samples. And then they were able to come back and tell me, these are the patients who have this mutation, and you need to consider sotorasib for these patients. That's the ideal situation, right? Is that someone's sending you this information rather than you're digging for it.
Yep, absolutely. Starting with the reflex testing, which is the way everybody should be doing it, where they can, running right up through this. And I know I've talked about it in the past for those folks that might be watching and who have watched in the past. We've had these conversations about GoTo and our relationship with the VA in screening, and having conversations a lot about this LPOP program and that biomarker precision medicine sort of piece of it. And we continue to be impressed with the work that the VA is doing and wants to continue to improve on. So I want to switch out of therapies for a little bit, and if you could really quickly go over a tumor board. What is a tumor board? Which patients go to tumor board? Let's start there.
Yeah, so Tumor Board is really a multidisciplinary meeting where we get together in a room. So at the VA, we have a thoracic tumor board that meets twice a month, so basically every other week. And we review patient cases. So not every single patient gets presented, but we do. Anyone can take a patient's case to Tumor Board. So oftentimes I'll bring cases, but it's very common for all my pulmonary colleagues to be taking cases where they were referred a patient with a lung nodule, and perhaps they attempted a biopsy, perhaps this is before they've even attempted a biopsy, and they want to run it by an interventional radiologist or a surgeon to take a look at. And so these are the cases that really involve multiple disciplines. We want to get sort of everyone's input in this one setting, and so it's great. Even during COVID, so we never skipped a beat. We've kept our meetings going. There's a virtual component to it, so we have Stanford radiation doctors who have been attending virtually even pre-COVID, and then many of us are kind of old school and continue to go in person. I think there's a value to us being in a room together, kind of sharing information and talking about these cases. And so that's something that we continue to do. And we generally meet for an hour twice a month. At Stanford, the Tumor Board takes place on a weekly basis just because of the volume. So usually depends on the kind of the number of cases, if you can kind of get them all in an hour. A typical Tumor Board will discuss usually 20 to 25 cases, which is a lot of cases. It doesn't leave a lot of room for each individual case, but it's very common for us to go over time as we're sometimes debating kind of what the best treatment approach would be. What I love about it is that it's not one person making a decision. It's really a group consensus recommendation. Some cases can be very challenging, and it can be tough for one person to kind of make the decision or call the shots. And so this is really sort of using the best available information we have. This is kind of the consensus recommendation. Our radiology colleagues are really terrific because they go through each and every scan and they prep ahead of time. So it's really a goal that we provide our cases to the radiology team at least a few days in advance so that they can review, and then they really kind of drive these cases moving as we're going through them, and then we all kind of chime in with our kind of thoughts on how to proceed.
Yeah, and from the patient perspective, I know in speaking with patients how comforting it is to them to know that their case has been reviewed by multiple experts, really coming together with a best decision and path forward for them. So we're all about tumor boards where they exist. I want to touch briefly on clinical research and then talk about some of this outside of sort of the regular treatment care resources that the VA has. But first, talk a little bit about the clinical research that's happening at the VA.
Yeah, so depending on the VA facility, I mean, VAs are really promoting research for every disease type, including cancer. So they really do have a research organization in place to allow clinical researchers like myself to have the infrastructure to open clinical trials. So I've been able to do that for lung cancer patients in my time at the VA because I work very closely with this sort of nonprofit. So almost every VA has this nonprofit that's associated with it that handles these contracts and budgets. And then they hire study coordinators, and then we work with them to basically assign staff and personnel for our individual projects. I've really been fortunate to be able to open a number of trials that are specific to lung cancer at the Palo Alto VA. And as you know, it's a dynamic process. There's new drugs that are constantly being tested. There's trials that are opening and closing. As soon as I know a trial is closing, I'm thinking about the next trial to open. So we partner very closely with our pharmaceutical colleagues to open trials. I think one of the things to be mindful of is you don't want to open a trial that may not really pertain to your patient population. So this is again where I think the clinical expertise, kind of that subspecialty expertise is really important. The kinds of patients that you're seeing in the kinds of trials that you're likely to accrue to. And same thing goes for the company. They don't want to necessarily have you open a trial that you're not going to be able to put patients on. So we, unfortunately, we can't open every single trial there is. And so we do have to think about the trials that we think are going to be really suitable for our veteran population. And thankfully, there's just so many opportunities out there. And so when I'm thinking about clinical trials, I wouldn't necessarily be opening a clinical trial at the VA and also the same one at Stanford. In fact, because of the differences in the patient populations, I see a lot of the trials are different at the two different sites. And so I think it's just, one of the major goals is to be able to offer veterans access to clinical trials. The VA does really promote that, and they want us to be thinking about this. There are national programs in place to allow veterans access to NCI, National Cancer Institute trials. So our VA, the Palo VA, has this big national grant called the Navigate grant that allows us to open trials fairly seamlessly, not just in lung cancer, but across different cancer types. With providing essentially a big sum of money and resources to pay for a study coordinator. And so that's something that we're able to do. And a lot of other VAs have other similar programs in place where they're able to offer not just lung cancer trials, again, really all types of trials. And we have interventional trials, we have translational trials where we're looking at basic science and trying to put it into clinical practice. And so there's a number of different kinds of trials that our veterans participate in. There's a lot of health policy research happening also within the VA.
Yeah, I think it's great. And I think it's great. And I think I'm getting feedback. I don't know where that's coming from. Sorry. I think that one of the things we talk about all the time here at GoTo is the importance of clinical trials, right? I mean, we've talked about the advancements that have been made, particularly in the last decade or so, wouldn't be possible without these trials, but more importantly, without the patients participating in these trials. So I just want to give a shout out.
We are
and
so grateful
to all of those
for patients.
Yes.
Participating
absolutely.
in trials. My belief is every patient should be on a clinical trial. That is the way we're going to continue to make progress.
I agree. And I think, breaking down that sort of, also stereotype that tends to be associated with clinical trials about it, being sort of a scary place as opposed to a place where most patients don't know. In most trials, you're either getting standard of care or trial drug, right? So you're getting treatment. It's, it's no longer the day where every trial has a, sugar pill, as a lot of people like to call it. So again, big shout out.
You'll be getting the standard of care, correct? Yes.
Yes. Last but sort of absolutely not least, can you talk a little bit about the offerings around symptom burden care and behavioral medicine services?
Yeah, I think this is really important. We actually have behavioral medicine or psychologists, as well as social work and a nurse navigator sort of embedded into our care model at the VA for all cancer patients. And we also have, as part of that, a nutritionist and then palliative care, as well as really referrals that we can place. But we have, kind of contacts for these individuals who are available to come down to our clinic when we need them to come. I think it's really critical. There's a lot of information that's getting passed on to patients when we're meeting with them for the first time. I'm now connecting them to our nurse navigator, who really kind of checks in with them again a few days later to just see how they're doing, with all this information, see what other additional resources. Our social worker will also be checking in with all of our new patients to make sure that they're connected to the benefits counselor, that their benefits have been maximized to the fullest extent, that they have transportation services whenever needed. The VA has a motel on campus. At the Palo Alto VA, it's called the Defender's Lodge. So really, distance doesn't really become an issue when we can offer these veterans a place to stay. So many times they'll come the day before their appointment, stay in Defender's Lodge, get their scans done, and then see us the next day. And so they're not having to do all this driving on the day of their appointment. For our patients who are getting radiation at Stanford, for example, they're staying at Defender's Lodge for the duration of their radiation treatment, sometimes going home on the weekends. But basically, we have a transportation system set up so that they're getting taken door to door from the Defender's Lodge to radiation. So there's a lot of these services that the VA provides. One of the other wonderful things that the VA can offer is hospice services, even for patients who are undergoing active treatment for their cancer. So outside of the VA, it's kind of either or. You're either on hospice or you're getting treatment. At the VA, we have it worked out so that we can offer patients with, advanced stage disease with patients who have a high symptom burden, the option of also enrolling in home hospice, which is just an additional support where they can get the day-to-day symptom management while getting radiation treatment or chemotherapy for their cancer. So that's one of the great privileges, I think, of being able to work at the VA and offer that type of a service. As you know, we as medical oncologists we're trying our hardest to do everything we can to treat symptoms, but there's this trial and error element of it, and day to day things can change, and so it's nice for patients to have the option to call someone and not be going to the emergency room when they're in a pain crisis, but to have the home hospice nurse to be able to call and to get hopefully immediate relief.
I love it. I think, I think that, veterans who may be watching live or will come back and watch this post live, I'm really hoping that they've learned a lot about the care. Dr. Das and I were talking before this. We could have taken any one of these questions and probably had an entire hour conversation about them and done a series on this. And I don't want to stop this conversation, but I do want to get to my friend Larry Gershon, who, as I said earlier in the program, is a veteran, a survivor, and an advocate. And happy belated Veterans Day to start with to you, Larry. I know that since your diagnosis, you've had experience with the VA. The VA on a volunteer level, Stanford, and your local community center. Can you tell us a little bit? Tell us your story and how all of this has kind of come together to work for you.
Well, just to quickly say how that all worked for me, I get my care in the community at a Sutter facility here locally, and I get second opinions and help whenever I need it through Stanford. I had a brain metastasis that needed to be surgically removed. I had that done at Stanford, in addition to second opinions I've received there. But I haven't done my care at the VA at Palo Alto. Instead of really focusing on my story, I think I can shed a little bit of light on the question about services at the VA. I am a retired veteran, and I am in the system there. What I do understand is not very much, but the little that I do understand is that there's a stratification within patients at the VA, and it's based on service disabilities. Those with the greatest disability have the least amount of responsibility in terms of copay and what have you. And since I don't have a service disability, I fall into that category where my copays would be the largest. I can't quantify that specifically, but so my choice about going to the VA was my own, that I chose not to. Because as a retired veteran and person who's old enough to be in the Medicare category, for me, the option that I chose was to be on standard Medicare with supplemental, and my supplemental comes from the military in the form of something that's called TRICARE. I have coverage that's called TRICARE for life, and so that's my choice about going to or not going to the VA for care. But I support what Dr. Daz said about all veterans are welcome there. It's a busy place. There are a lot of veterans in some areas, and so it can be challenging at times. But I do have retired colleagues and friends, Navy friends that I served with, who do receive their care, their primary care, and any specialty care as well at the VA facility in Palo Alto.
Do they share with you how they feel about the care there? I can't imagine it's anything but glowing based on the conversation we've had tonight.
Now they're very sad. They're very happy about it. It not only are they getting good care, but but there's a camaraderie when you're there that is very unique. The doctors understand veterans. I assume that some of the doctors there may even be veterans themselves. But having spent time around veterans as doctors, I think they pick up on what's important to veterans. And I know the people that I know that are served there really, really appreciate the care they're receiving.
So, Larry, I'm going to step outside of this a little bit, and not selfishly, I think for patients who maybe don't know whether they're being seen in the VA or outside of the VA, what has your experience been like? Let me step back. So I mentioned a little bit earlier, some of the work, and I just touched on it, some of the work that we've been doing with the VA, particularly as it pertains to screening in this early detection space, and some other legislative stuff that we've been working on. And Dr. Das and I, prior to this meeting, she received, I don't remember if she said it was an email or a phone call from Dr. Drew Moganaki, who recently came out here to the West Coast from the East Coast. And he's an integral part of the conversations that we're having and trying to figure out what the best way might be. So Dr. Das was saying that she wants to have a follow-up conversation about what go-to services might be appropriate to bring to the veterans who are diagnosed with lung cancer. And I know you are intimately involved with go-to. So in your opinion, what might some of those services be, and how have they impacted your experience?
Well, number one, I would say the living room. Encouraging veterans to watch the living room, and I think even more so probably next month, Danielle, because you're addressing small cell lung cancer, which I think is, Dr. Das can confirm or dispute the comment, but I think it's probably pretty prevalent at the VA, and I'm sure a lot of veterans would really benefit from that discussion, learning how go-to is focusing on small cell lung cancer, and but in general terms, the living room has educated me and empowered me to be my own best advocate and to be actively involved in my treatment decisions, and then a program that's very near and dear to my heart is the Phone Buddy program, and I'd love to see the Phone Buddy program expanded into being able to help veterans. I experienced it one-on-one and personally in the living room because I found people there who had walked in my shoes. But being able to talk to someone in other parts of the country and relate to what they're doing and letting them talk to their issues with someone who's walked in their shoes. And I think the Phone Buddy program would be an amazing extension to the VA.
I think that's great. And so for those of you who aren't familiar with our Phone Buddy program, it's a peer-to-peer mentorship program, and Larry is a mentor in this program. So Larry, being further down the road in this experience with lung cancer, is able to have conversations and mentor and help some of the people who are earlier on in their diagnosis with some of the challenges that they're having even outside of their treatments, right? With some of the emotional and mental aspects to it, some of the concerns. I think a lot of times we know that, patients, and I have this personal experience with my lung cancer loved one survivor, doesn't really want to talk to their caregivers or their loved ones about their fears or what they're afraid of, because they feel like they're already a burden to some extent, and they don't want to further burden their family members or friends with some of these concerns outside. So this really is a space, a safe space, where we match people as closely as we can in age and diagnosis and family, family style, to one another, to be able to share some of these experience. And how many phone buddies do you have right now, Larry?
Active at the moment, I have 7, but I've had
Yeah.
many more throughout. It's a unique experience. Some people only want answers to 1 or 2 questions, so their need is very specific, and that can be dealt with 1 phone call. But I have buddies that I talk to on a regular basis and have been with them for years, and it's a really rewarding experience for me. And I just want to add, Danielle, that the phone buddy program is expanding slowly into the area of supporting caregivers as well, and I'm sure that could be an area where the VA could take advantage of the program also.
Thanks, Larry. So that was like a commercial for the lung cancer, the Go To Lung Cancer Foundation's Phone Buddy program. But I think it is important, and I hear from patients, sadly, all too often, how they feel sort of alone and isolated in their diagnosis. And this is just one area, even outside of the living room or some of our online communities, where patients can connect and feel like they're part of something that they can relate to. So thank you. Larry. Dr. Dass, I think you were going to say something.
No, I think it's, Larry, I think it's so important that you bring up the caregiver issue. And we always do focus on the patient, but the caregiver aspect, I think, is we're recognizing that it's equally important to really reach out to the caregivers, because they're really helping that person, the patient, through their treatment process. And it's I think it's long overdue that we pay attention to that as well. So I'm so glad to hear that Go To is actually thinking about that as well. And I just think that the VA would be a great place to have something like the Phone Buddy program, because of that camaraderie that you mentioned, Larry, that already exists. I think it's just an extension of that.
Thank you, Dr. Dass, for the commentary. I am we're already 7 minutes over, and I promise I won't keep you longer than maybe 5 more minutes. But I do want to talk a little bit about Lung Cancer Awareness Month, Lcam, as it's fondly referred to in the lung cancer community. I hope you've all been following some or one or all of the awareness campaigns that have been going out all month for lung cancer awareness, and let you know that it's not too late. If you haven't been able to give a shout out yet or jump on board, you can still spread the word. If you'd like to participate, you can in a couple of ways. You can, of course, go to the Go To Foundation website at gotofoundation.org and download our Lcam Toolkit. In our toolkit, you'll find various ways to kind of grab and share different awareness pieces through your social channels and other places. And this next one is an important one because it does have sort of this deadline time stamp on it, but we do need your voice. We've talked a lot about the specifics of lung cancer, early detection, diagnosis, and treatment today, but we haven't talked about the other piece of what Go To Foundation does, and that's in our government affairs and advocacy work. So we do need your voice. You can advocate for change by bringing that voice, those strong voices that I know are out there, to your senators. What's the ask? Well, I'm going to tell you. And you don't need to write this down because it's all available on our website. I think Rocky behind the scenes there is going to put the URL up there, but you can also find it from our homepage. And then once you land on this to sort of take action page, it's literally one click for you to compose and send an email right away out about Senator Mark Rubio's amendment number 4335. We've been working with Senator Rubio, and he has offered an amendment on lung cancer research to be added under the National Defense Authorization Act. This amendment will establish an interagency review to evaluate and identify opportunities for the acceleration of research on what many of you who have been connected to lung cancer, to Go To Foundation for Lung Cancer, know is the Women and Lung Cancer Preventative, give people greater access to this preventative service and strategic public awareness and education campaigns on lung cancer. The Senate is not willing to take up the amendment unless we demand action now before the first session of the 117th Congress ends, which is literally this week. So if you can and you would, please consider over the next couple of days jumping onto our website. Like I said, it's one click. You just sort of input the information you want to around advocating for amendment number 4335. Again, that's Senator Mark Rubio's amendment. And then one final thing I want to just add on about some of the work that we are doing legislatively to support our veterans. Back in 2020, GoTo Foundation joined the veteran service organizations in supporting two key pieces of legislation that we believe will benefit those serving in the military who are at risk for lung cancer or and current veterans. GoTo Foundation endorses S4393, which is the Toxic Exposure in the American Military TEAM Act, which creates sweeping mandates for the Department of Veterans Affairs to further research, track, and care for eligible veterans. And we also endorse HR 8261, the Presumptive Benefit for War Fighters Exposed to Burn Pits and Other Toxins Act of 2020, because it lists a number of diseases, including all forms of cancer and lung diseases, that would be given automatic presumption of service connection associated with the disease for veterans exposed to burn pits and other toxins. This is a bill that comedian activist, some of you may or may not know, Jon Stewart, has publicly spoken at press conferences about. This whole policy arm is led by an amazing team of folks at GoTo Foundation. And as you can tell by my fumbling over some of these words, it is not my area of expertise, but I promise you that if you do go to our website and land on this Take Action page, you can not only help us with the ask by the end of this week, but learn more about some of this legislation that we are currently endorsing and supporting. So I'm going to ask Dr. Doss and Larry for any final thoughts before we close out and say goodnight to everyone.
Danielle, I'd just like to address your comment about the Take Action page. I did it today. It'll take you longer to find the Take Action page than to complete the emails to your senator. It's all there for you. You can add whatever comment you want, but it's all done for you. All you have to do is push the button, find the page and push the button.
Thanks, Larry. I appreciate that. As always, for you being one of our number one supporters. And the email address, I'll just say it and I'll say it slow, is gotofoundation.org/advocacy /take action, and then one more backslash. And that's where it's a click away. And we are working on our website, on improving our website and the navigation. So I'm sorry it was so hard for you to find today, Larry. Dr. Doss, any final words before we close out?
No, I just wanted to thank you for this opportunity. I think it's really wonderful to be able to have this chance to talk about the VA and the great services that we're able to offer, and hopefully allow people to feel more comfortable with receiving their care at the VA and knowing that we are really here to serve you, and it's our privilege to care for you. And I just want to again thank you all for tuning in, and thank you for this invitation and for celebrating Veterans Day and Lung Cancer Awareness Month this way.
Thank you so much. We can't thank you enough for coming in and really not only putting a face behind the care that patients can expect to receive at VA, but for doing such a stand-up job into the development of your what is very clearly a comprehensive lung cancer program. And we hope that once we do go back live and in person, you'll be able to come on down and join us here. As Larry stated a little bit earlier, next month's living room, I just want folks to note that there is a date change. It's normally the third Tuesday of every month. This month, due to the holiday, it will be on December 14th, so the second Tuesday, and the Gatherly Social Hour will be right before. We'll be communicating out to you about some of these changes, but we do have Dr. Charles Rudin from Memorial Sloan Kettering and Jennifer King, PhD, who's our Chief Scientific Officer at GoTo Foundation, talking about the advancements and research in small cell lung cancer, and really talking about some of the work that GoTo is doing to create community around small cell lung cancer. So what, 15 or 17 years ago when I started in this space wasn't even available for non-small cell lung cancer patients is still not available for small cells. So we're putting a lot of effort into to creating that community for you. So I really hope that you guys will join in. And like I said earlier, I said I would remind you that if you want to get regular updates and reminders on not only this program, but all of the services that GoTo Foundation offers our patients and caregivers, please consider going to the Living Room page on our website and join our patient caregiver community at gotofoundation.org/living room. Thank you again to Dr. Das, Larry, as always, all of you watching live or post-live, Peninsula Television, for helping us on the back end of this as we pivoted very quickly to a virtual-only lung cancer living room. And then our GoTo team, the staff, the entire staff, all my colleagues at GoTo, thank you for all your efforts, not only in helping us to develop this program, but for all the work you do in your own areas of expertise day in and day out. Obviously, I want to thank our supporters. Without their support, we simply could not bring this or other programming to you. Amgen, AstraZeneca, Bristol Myers Squibb, Daiichi Sankyo, Foundation Medicine, Genentech, Lilly, Oncology, Merck, Novartis, Regeneron, Sanofi, and Takeda. Thank you all. Have a good night, and we'll see you next time.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.